Hello, Chairman and everybody. And thank you, Chinacon, asked me to join these meetings. And my topic is arthroscopic Chinese unity lay bracing for the treatment of recurrent dislocation of the shoulder. And this history of the patient is 31 males and repeated dislocated of the left shoulder for 10 years. And so up to now, the patient has been dislocated for more than 10 times. After the reduction, the shoulder joint has no obvious discomfort and immediately returned to normal life. No previous underlying disease. And the physical examinations, we can see the relocation test and the operation test are positives, and the sulcus is negative, and the range of motion is nearly normal, and the rotator cuff is normal. This is the examination. We can see under anesthesia, we can see the anterior dislocated. And this is my examination for the dislocated people. And we can check the patent score is higher, and the shoulder external rotation is up to 90 degrees, but the rotator cuff is normal. We can see belly press, external rotation, and this is the check for the rotator cuff. It's normal, can see. And also including the biceps is also normal. But the release relocation, yes, is positive. Okay. And this is a pre-operative CT scan, so we can see the anterior, I think almost 10% of bone loss. And the coracoid is nearly normal, and it's good. And the bone quality is also good. And we can see clearly the haystack lesions. And this, I think, diagnosis is no problem. And I will do the unique lay bracing. And this is a description of this procedure. So usually we will make a hole at the glenoid and then reshape the coracoid at the same side and then fix the coracoid to the hole. And this is the portal for the system. So you can see usually we have the anterior lateral portal. This is just the lateral one centimeters away from the anterior lateral cortex of the acromion. And then the anterior inferior is just 3 finger depths under the coracoid. And then the anterior superior is just close to the clavicle. This is and also normal posterior portal. This is a portal we can see from upper side. And this is special tools and for the system I designed for the 2-direction guider for the position, and then 2 kind of drill we have to use. One is drill for the glenoid, and the other is for the coracoid reshape. This is a procedure. We can see this is the anterior, and we just open the interval, and then we reshape, and the combined tendon at the posterior part. We separate combined tendon from the subscap, and then the combined tendon, the lateral part, we have to remove, and also the under part of the coracoid. And then we also cut down the coracoid acromial ligament, and then we separate the combined tendon, also the pec minor, and from the pec major, we can see the space. And okay, and we can see the axillary nerve. Then we move the scope to the anterior inferior, and from the posterior, we also remove the upper soft tissues and also the medial side. We cut down the pec minor from the coracoid at the medial side, just close to the coracoid, and then a little bit down, also separate from the pec minor to the combined tendons. And then we remove the muscle member of the subscap, and also separate a little bit the pec minor from the combined tendon. And here we should be careful, because we can see this is the nerve. The most important is the cutaneous nerve and also axillary nerve. This is axillary nerve, and this is the cutaneous nerve. So we remove the soft tissues, and then we also remove of the soft tissues around the coracoid. We just remove about 16 millimeters is okay. So usually we check about 16 millimeters. This is a guider. You can see the point is from the tip of the coracoid to the base is 16 millimeters. And then we remove the cortex from the base of the coracoid, especially the underside. And also the medial side and the lateral side. Now this is from medial side, and the shape already moved to the medial inferior portals. Then we will structure the lateral part of the combined tendon just close to the coracoid, and this is for hold of the coracoid and also for fix. So we just use I like to use a orthocord. Then we use a curved carve and cut down the coracoid from the upper side. Usually, we first make a medial and lateral, then the middle. Now we have cut down the coracoid as a position we like to that, and then we move the scopy to the anterior lateral side, and then we can make a KY to move away the subscap, and then we debride the anterior labrum from the glenoid. You can see, so detach the capsule and the labrum from the glenoid, and then we can see we remove all the soft tissues. Until to the muscles. And then make a refresh of the glenoid, and we push the capsule as lateral as possible. Then we use another changeable bolt rod and pass through the subscap anterior, just on the surface. And also we protect the axillary nerve. So we can see we use protect the axillary nerve, as we pass the subscap about the end of the middle. Then we remove the lateral part of the muscle until to the tendon. And then we push up the upper part, and then we separate the medial muscles, makes the hole bigger. Then we pass a PDS suture through the hole and pull up the upper part and change to a stronger sutures. And the end part, you can see we can push down by the interchangeable rod and remove the soft tissues and expose glenoid. You can see clearly the glenoid exposed well. And then we push our guider from inferior medial to the joint, and then open the lateral range. So we can see we already opened the two direction guider, and then this is another guide for drill, and also protect the soft tissues. I will make a hole about 10 millimeters in depth and 7 millimeters in depth and 10 millimeters in diameters. This is the hole just beside the surface, about 1 millimeters. Then we push a suture there. And this suture, we will put it together with the coracoid. This is a coracoid. You can see make a little bit holder, bigger, and pull the coracoid to the outside, and then we hold the coracoid at the middle. We drill hole, then we make the base smooth. And with a shaver to reshape the coracoid and make 10 millimeters in diameter and 7 millimeters in depth. Okay, we remove P-wire and we check it's only 10 millimeters left. It's okay. And then make a suture through the middles and we pass the suture to the hole. And this is a screw. And at the tip of the screw, there is a hole. So we can make a suture, pull the screw until to the tip, just to the tip. And then we'll pass the suture through the suture of the middle. Then the drawing sutures will pull the coracoid just to the hole. And we close the bigger hole to prevent the waters. And then we use arthroscopy to the inside. And we can see, yes, it's a coracoid and the screw. And it's already pulled close to the hole. Then we use another guider to push the coracoid to the hole. Okay, and hold it. And we will make sure it's already to the hole. And then we use the driver and tighten the coracoid. This is also a special design, the screw. Then we pull the suture at the base of the combined tendon to the joint. And this coracoid is already stabilized as a whole. And then we just make the suture to the joint and make another fixations to prevent rotations. We can see the coracoid, the position is good, and already contact to the surface very smooth. And then about as a 3 o'clock, we'll make a hole of push lock. Then we pass the suture of combined tendon through the capsule. And this is the procedure of capsule make a bunker repair, and also is protect the coracoid from the joint fluid. And then we tighten the sutures. This is we can use a bunker. Okay. Finally, just after the surgery, we can see the CT scan, and the position is good, and the surface is too smooth. And this is the screw. The screw, you can just pass the opposite cortex, and we can see the emphasis view. And the screw is just 2.5 in diameters. And this is also the 3 weeks post operations. You can see already healed. And now we can also ask patient to start to do the range of motion and normal. Thank you.
Good afternoon, everyone. Hola a todos. Well, thank you for being here. We will start this section. This section is hosted by the SBCJ, which is the Brazilian Society of Knee Surgery, and we will talk about the anterolateral structures of the knee. So my name is Camilo Elito. I'm from Brazil, and I would like to invite our first speaker, is Dr. Max Barahona, my friend, who will talk about anatomy, biomechanics, and imaging evaluation of the knee anterolateral complex. Max, please.
Bien, muchas gracias por la invitación.
Okay, thank you very much for the invitation.
¿Hay problema? A ver. Sí. Bueno, estos son mis conflictos de interés. Hay un renovado interés por el estudio de las estructuras anterolaterales.
These are my conflicts of interest. There is renewed interest in this area. You can see in the graph how the publications have increased exponentially, but over history there have been a number of descriptions of the structure receiving many names. This has led to controversy in terms of how we should refer to it and how to communicate to express ourselves about it. The agreement nowadays is that we should speak about the anterolateral compartment. In that compartment, we find three structures: the tibial, the tibial band, the anterolateral ligament, and here we can find a study by Vincent Kleitz, an editor. And we can see that it comes proximally towards the distal and anterior part. It is a single structure that is different to the tibial band, and according to their description, the most similar thing in the history would be Jack Houghton in the 70s. The ligament behaves as a ligament. It is present from fetal development. It has a base that is wider distally. There are three insertions. The first is the tibial, which is 6 millimeters distal from the joint line and halfway between the tubercle and the tibula fibula. The femoral insertion generates controversy. The condyle is in the same place as the lateral joint and posterior and proximal to the lateral condyle. And the last one, let's say that the consensus has been that it should be inserted in the femur. It also has a meniscal insertion that is in the union between the horn and the body. And there are a number of studies that we can identify. We generally recommend that you find the crest with good identification. You can identify insertion at the level of the meniscus. As for the tibial band, this is distal from the fascia lata. Together, the whole structure of the pelvis can be divided into two. Fascia lata and the more distal portion that is more ligament-like. This distal portion can be divided into two, the anterior and superficial part, and the posterior part, which is more deep. The insertions of the BIT, there are 5. The first is most distal. It's the insertion where you would insert the tubercle. It's well known. And then the anterior, more superficial one would be on the lateral face of the patella. And at a proximal level, you have this line and the structures, the Kaplan fibers. They've been described as such, and they've been reviewed recently. Here you would describe that the most distal band of the Kaplan fibers is the biggest one, the widest one, the thicker one, and the longer one. And it's they're also proximal to the condyle. As for the imagery in the study, there was a cadaver correlation and an image correlation. You can see structures where we have identified the proximal part and the distal part of the Kaplan fibers, and also in 1.5 Tesla imaging, you can see that it's more complex. It's difficult to know whether it's distal or lateral, and it's easier to find this through the lateral incisions with the insertion of the tendon at the lateral level. Despite that it's easier to find the lateral cuts, it's also possible to look at the axial cuts and the crest, and you can see the capsule osseous insertion that is more ligament-like, and in this work it was reviewed. We defined that there was a slightly more posterior insertion to the ERD tubercle, and this corresponds to the description of Vincent at the beginning of the century, where you can observe this insertion. Proximal in the condyle and distal in the tibia, at the level of the tibia. There was a study recently which is different to other studies. It's a posterior dissection or a posterior approach to the band, and we can see that photo D has an asterisk because it's more distal to Kaplan fibers, and it's an insertion site for the iliotibial band, and the doctors have described that this behaves very similarly to what Vincent and Terry did in the 80s as a point of reference, with the function of the ligament in a tenodesis, and it's more tense rather when it rotates internally. In the same article, as we mentioned before, there are different structures with the anterolateral ligament. From a biomechanical point of view, I wanted to highlight this study that was where we had two randomized sequences of resection, both for the anterolateral ligament fibers and also Kaplan fibers, and we observed that both sections, these two structures increase significantly internally, and with internal rotation from 0 to 90 degrees, and the contribution of Kaplan fibers are slightly more significant in terms of degrees, and in previous studies which motivated a number of editorial laters, there was more contribution from the band as such. As for pivot shift, both structures show synergy with the production of previous translation of pivot shift, and also contributions are greater as you flex, as you increase flexion. If you have anterior translation, the same thing happens. There is synergy between the two structures, and you create a greater effect as you increase flexion, in this case to 90 degrees. This study shows something quite similar. It was also applied on the left-hand side. You can see internal rotation and the contribution of these two structures, or the anterolateral compartment with flexion and strength anterior to the tibia. In this work here, you can see that a black line has been marked at the level of 20. This is when you change from grade 2 pivot shift to grade 3, and it's touching each of the specimens here, this line, and the anterolateral complex is green. You can see only 4 specimens did not go on to grade 3 pivot shift. Message to take home is that we need to communicate using the adequate language, the anterolateral complex, the anterolateral ligament, BIT. It has a role in controlling internal rotation as well as anterior translation. They work in a way that shows synergy, and relevance is comparatively or augments comparatively with flexion, and these structures can be identified in MRIs. Therefore, we need to train and evaluate those systematically for a better diagnosis in our patients. Thank you very much.
Thank you, Max. It's very good to have a friend from Slard here. I think the next lecture will be Professor Zanfanini. He recorded his presentation because unfortunately he couldn't come. Could you put the presentation, please?
I'm so sorry to not be in Cartagena with all of you. I miss you all, but I will show my experience, long-term experience with ACL plus extraarticular reconstruction at Rizzoli Institute. ACL reconstruction has no gold standard. There are different techniques depending on graft choice, graft diameter, femoral tunnel placement, fixation methods, and the adding of lateral plastic. That is sometimes different. Just in 2013, there was a new discovery of anterolateral ligament. Are ACL reconstruction really anatomic? But this ligament is already been described before Werner Müller in even in 800. There were some authors that described this type of ligaments, that it was a sort of increasing of the lateral capsule of the anterolateral part of the knee. Since 1993, we describe this type of technique that is using hamstring tibial attachment maintaining. We don't perform femoral tunnels, so we go over the top, and the fixation is with the simple staples, and we add the lateral plastic, that is the addition of the same graft that we use for ACL, that we perform the lateral plastic. So in this case, we don't have any sort of increasing morbidity in relation to the use of iliotibial band part that can be detached from the femoral side and then pass below the tibial, the lateral collateral, as most of the people does now. But in this case, we avoid the use of any graft because it's the same graft that we use of ACL. And this is a sort of combination of, really combination of inter and extraarticular. We try in these 25 years of results with this technique, trying to demonstrate the efficacy of our technique. And in fact, this is a paper of 2009. We evaluated in vivo with navigation the effect of lateral plastic, and we saw that any step of the procedure decrease the translation of the knee, and mostly of the time is reducing the adding of the lateral plastic. There is the reduction of AP translation of the lateral compartment. In 2017, also we performed this cadaveric study where we evaluated the effect of adding to ACL the anterolateral section, and we evaluated a single bundle plus lateral plastic, and the effect of this was restore baseline laxity, rotation and pivot shift better than non-anatomic double bundle. Also in this study, where we compare three techniques, we found that over the top plus lateral plastic versus anatomic single bundle versus non-anatomic double bundle has a better laxity reduction at AP90 and rotational laxity. Also, we prospectively evaluated the group of patients that we started at 3 years, 5 years, 10 years, and 24 years follow-up, and where we perform the same group of patients that were evaluated prospectively in all these series and in all these papers. Also, we evaluate the safety of our technique, and in fact, we take 2,500 consecutive patients, and we found that the cause of readmission after 90 days was only 2.27%, and most of the cases was really deep, some swelling, and some very, very few cases of infection. Also, we evaluated the graft maturation in relation to the fact that our technique maintain the hamstring insertion on the tibia. And in fact, in this MRI study, we've evaluated that there is better tunnel integration, there is improved clinical score correlation with the signal, and there is hypointense graft signal signs at 4 months. Also, we evaluated 244 cases at more than 10 years follow-up, and we found that there is an overall revision rate of 13%, and 3% was revision, 4% was meniscectomy, and then 5% was staple removal. So it's really very small type of reoperation. Però gli stessi pazienti poi fate il controllo. We found also that in these 245 cases, we found that there is an increase 2.4 increased the risk of contralateral injury, and especially in young patients, especially that they are below 18 or 20 years, and active patient, but there is no difference between sex, age, and activity level. Also, we did the PROMs, so not only the objective data, but also the patient-reported outcome. And we found that at minimum 10 years follow-up, there is 73% that is excellent, 15% good, and only 3% of poor results. The worst sport and quality of life is in female and patients that has already, at the time of surgery, outer bridge more than 2. This is the long-term follow-up study where we evaluated the 29% at more than 24 years follow-up. Age at surgery was 25, age at follow-up 49. And we saw that there is still 86% of patients that are AKDC A and B, 62% lies on good or excellence, and 41% is still doing high moderate impact sport, and only 14% has positive Lachman or pivot shift. So in conclusion, I would say that all these lot of paper that I show you, our technique has a solid biomechanical rationale, has potential biological role of graft insertion preservation, has a low percent of revision, 3-4% at the long term, limited number of reoperation, then good long-term PROMs and sport activity, a low degree of A, higher when concurrent different technique. So thank you very much to all, and I hope to see you soon in person to all. Bye.
Thank you, Professor Zanfanini, for this great presentation. And now I'd like to call my friend from Brazil, Aloysio Carneiro, who will talk about other causes of pivot shift grade 3.
Olá, boa tarde.
Hello, good afternoon. Forgive me because I don't speak Spanish. I think it would be more catastrophic that way. Therefore, I will speak Portuguese. I'll try to speak slowly so you can understand me.
Do Brasil. Coube a mim falar sobre as outras causas do pivot shift. O pivot shift é uma manobra multiplanar complexa, tem translação e rotação. Ela correlaciona normalmente com os resultados clínicos, né, funcionais. O paciente normalmente tem um pivot shift mais intenso, ele tem uma capacidade funcional inferior. Graduado de modo subjetivo, em trabalhos cadavéricos, você gradua em grau 1 de 6 a 8 milímetros, de grau 2 até 15 milímetros, e de 20 a 25 você bota como grau, se classifica como grau 3, mas é subjetivo essa avaliação clínica. Trabalhos que visaram, né, serviços que fizeram trabalhos usando o auxílio de softwares, de computador e de tablet, para fazer essa graduação de uma forma mais objetiva e mais correta, conseguiram classificar como baixo grau 40% dos pivots e alto grau 60% do pivot. A meu ver, o mais importante ao se analisar esses trabalhos é que você identifica que o pivot ele é multifatorial. Várias estruturas e eventos colaboram com a presença do pivot e o seu tamanho, né, o seu grau. O LCA, os meniscos, a raiz meniscal, o ligamento menisco tibial, ligamentos colaterais, a banda iliotibial, cápsula e a morfologia, a anatomia femoral e tibial. Todas essas estruturas colaboram e fazem parte da gênese do pivot shift. A lesão meniscal ela tem um importante papel na instabilidade do joelho com o LCA insuficiente, como todos nós já sabemos, o menisco é um estabilizador secundário, mas o que vale a pena é que, quando se vai para a literatura, se identifica que a importância do menisco lateral, né, a relevância do menisco lateral no mecanismo do pivot shift, muito mais importante do que o menisco medial. Esse trabalho aí mostra que lesões capsulares, lesão meniscal, medial e lateral, estão associadas ao aumento da instabilidade rotatória do joelho com deficiência do LCA. Essa outra avaliação, né, fazendo uma análise da meniscectomia medial e lateral, o trabalho mostra que quase não há diferença entre o joelho com meniscectomia lateral unicamente e o joelho com meniscectomia medial e lateral, mostrando sim a relevância da lesão do menisco lateral na instabilidade do joelho, né? Esse outro mostra que a lesão do menisco lateral ele aumenta não só a translação como a aceleração do pivot shift, mais uma vez colocando como é importante a lesão do menisco lateral deve ser mais valorizada do que a do medial. E esse mostra, né, que, falando sobre o efeito da lesão da raiz do menisco lateral, mostra que a combinação da lesão do raiz menisco lateral ela aumenta a instabilidade do joelho com a deficiência do LCA, sinalizando para o menisco lateral ser um estabilizador secundário importante durante o mecanismo do pivot shift. A lesão menisco tibial, a lesão em rampa do menisco medial, também tem uma importância muito grande, né, dentro da composição e da gênese do pivot shift. Esse trabalho mostra que a lesão do menisco capsular e do ligamento menisco tibial no corpo posterior do menisco medial, ele aumentou o pivot shift. Nos pacientes em que foi feita só a reconstrução isolada do LCA, não houve a restauração do pivot shift. Então, mostrando que realmente é muito importante a pesquisa e a resolução do problema da rump lesion. Já esse estudo biomecânico, ele já não coloca com tanta relevância o reparo da lesão em rampa, né? Isso eu acho que para nós não serve para sinalizar como desprezo da função do menisco medial, mas sim dar mais importância e maior preocupação com a lesão do menisco lateral. Quando falamos da anatomia óssea tibial, nós sabemos já que o aumento do slope tibial, ele aumenta em muito a chance do paciente ter uma lesão do LCA e aumenta a instabilidade rotatória. Esses trabalhos aí mostram que a inclinação tibial, um slope maior que 7 graus, aumenta em muito o risco de lesão do LCA. E quando o slope lateral é maior que 9 graus, isso é um fator preditor muito importante para a instabilidade rotatória do joelho. Então, temos que estar atento também à anatomia óssea. A anatomia óssea do femoral também é relevante na composição da instabilidade rotacional do joelho e na composição do pivot shift, né? A profundidade do côndilo femoral lateral ela é associada a uma maior instabilidade rotatória, como mostra esse trabalho. Esse outro fala do índice condilar femoral lateral, como um importante fator de risco para lesão do cruzado anterior. E quando se pega, por exemplo, um trabalho como esse, que pega os fatores que foram encontrados como mais importantes na associação do pivotivo de alto grau, todos esses aparecem e o offset do côndilo femoral distal é um fator importante e relevante no risco de um pivotivo de alto grau. Outra coisa que temos que ficar atento é o sinal radiográfico da fratura por impacção no côndilo femoral lateral, né, que pode ser visto como uma identificação do paciente com alto risco de instabilidade rotatória, principalmente se esse sinal tiver mais de 2 milímetros de profundidade. Esse outro trabalho mostra que se a lesão tem mais de 1,8 milímetros de profundidade, isso já pode ser considerado um sinal quase que patognomônico de lesão do LCA associado ao ligamento anterolateral, e que esses pacientes têm um risco 4,2 maior de instabilidade residual. E nesse outro fala que essa imagem, né, maior que 2 milímetros, essa imagem da fratura condral no côndilo lateral, é um fator preditor de lesão da raiz posterior do menisco lateral. Quando vamos analisar as estruturas anterolaterais e banda iliotibial na gênese, né, do sinal do pivot shift, sabemos já da sua importância e como são estruturas fundamentais. Esse trabalho, fazendo a simulação do pivot shift, ele mostrou com a banda iliotibial foi o mais importante restritor do pivot shift, por ser um restritor primário na rotação interna do joelho entre 30 e 90 graus. A cápsula anterolateral e o ligamento anterolateral não tiveram uma importância menor como restritores na rotação interna. Esse outro teste robótico, né, fazendo uma simulação do pivot shift e avaliando as forças in situ do LCA e das estruturas anterolateral, mostraram que o LCA foi o principal restritor nos menores graus de flexão. O LCL e a cápsula anterolateral compartilhavam nas maiores angulações, em ângulos maiores. E o ligamento anterolateral teve uma função limitada. Isso se falando na simulação no pivot shift, onde se faz a rotação interna com o joelho com a extensão. Então, a estrutura mais importante avaliada seria o ligamento cruzado anterior, realmente. Como conclusão, temos que levar a mensagem que o pivot shift é multifatorial, que há aumento das evidências que as lesões meniscais, meniscos capsulares, cápsula anterolateral, desempenham função importante na estabilização rotatória do joelho. E que temos que estar atentos a sinais adicionais, a sinais de fatores ósseos, como anatomia tibial e femoral, nós temos que observar e temos que estar atentos a ela. Graças.
Thank you. We had a slight modification in the program because Dr. André Kuhn couldn't come. So I would like to call Dr. Vítor Marques, who is the
Gracias.
current...
Quiero llamar al doctor Víctor Márquez, quien es el presidente de la Sociedad de Rodilla Brasilera. Doctor, por favor.
Buenas tardes. Me
Good
gustaría
afternoon. First of all, I would like to say sorry about the language barrier. I understand Spanish, but I don't speak Spanish well. So my talk will be in English.
It's okay. Well, I'm Victor, and I'm a member of NI group of Pavilhão Fernandinho, Simons, Santa Casa, São Paulo, and I'm the current president of the Brazilian Society of Knee Surgery. And first of all, I'd like to thank the organized committee of this Congress in Dr. Manuel Mosqueira for inviting me to speak about indications of anterolateral ligament reconstruction. Despite the high rate of good results, ACL reconstruction has two reasons to be concerned. The first one is the residual instability, around 15 to 25%. And the second one, and the most important, is the ACL graft rupture, around 1.4 to 18%. And how do we solve these issues? The way to solve these issues seems to be anterolateral ligament reconstruction, and there are some evidence on this. But who needs this procedure? Some papers recommend this procedure in the population at risk for graft rupture. And this population are young women, patients who want to return at the same level of sports practice, elite athletes, and patients who want to return to pivot and contact sports. In this population, the rupture rate is much higher than the normal population, around 18 to 28%. And the reoperation rate is similar to this rupture rate. On the other hand, the first international consensus in 2015, Lyon, France, with participation of Camilo Elito and Vitor Barahona de Padua, they concluded that the indications of ACL and anterolateral ligament reconstruction depends on three factors. The first one is patient history, such as ACL revision and contralateral ACL rupture. The second is clinical and image evaluation, such as pivot shift grade 2 or 3, Lachman test above 7 millimeters, second fracture, and deep lateral femoral knot sign. And the last factor is patient profile, such as pivot sports, hyperlaxity, and patients under 25 years old. And they classify some as a decisive criteria with this red border, like ACL revision, and others as a secondary criteria. And the minimal requirements for indication for anterolateral ligament reconstruction are just one decisive criteria or two secondary criteria. In the second international consensus in 2017, there were some changes, and the appropriate indications were high grade of pivot shift, ACL revision, generalized ligament laxity, genu recurvatum, and young patients return to pivot activities. And there is also this guideline made by these colleagues from Argentina. And in this guideline, they used major and minor criteria for indications of anterolateral ligament reconstruction. However, in my practice, my personal indications are high grade of pivot shift, and I thank you, Sergio Canuto, for this excellent video showing the high grade of pivot shift. The second fracture, and thanks Canuto again for the images. Patients who want to return to pivot and contact sports. Almost almost ACL reconstruction revision, and young women and patients under 20 years. And by the way, she is my oldest daughter, he's my son, and she's my youngest daughter. And thanks God, their knees are okay. Oh, sorry. I would like to take this opportunity to invite you for our Congress next month in São Paulo, Brazil, from 20 to 30 of April. And thank you very much for your attention.
Thank you, Vitor. Now it's my pleasure to call Dr. Andy Williams, for sure one of the greatest knee surgeons in the world, and certainly a guy that supports a lot of extraarticular reconstruction, especially in high-level athletes. Andy, please.
Okay. Ladies and gentlemen, Camillo, thank you so much for that introduction. You're extremely generous and very kind. So it's a great pleasure to come and present more of our clinical follow-up of our elite athlete group. Now, I've been using lateral tenodesis for many years. Over 15 years ago, I was using it for all my revision cases. And this is the reason why. It's a logical thing to do. If you look at this schematic diagram, the big orange oval is the top of the tibia. The small one represents the fibula, and the gray circle is the center of axial rotation, just in the medial compartment of the knee. Now, if you look at the ACL, it's really, really well aligned to resist anterior tibial translation. But its lever arm to control rotation is actually really short, and therefore it's in a difficult position. But if you put something, or there's a structure on the lateral side of the knee, the lever arm is really big. And so it's a very powerful way of controlling rotation. Now, traditionally, I did this operation, which is very popular in the UK in the 70s, 80s, the Macintosh. Very big incision, a big wound, and we felt that perhaps we could do better. As some of my research has already been shown today on the biomechanics of the lateral structures, and I have to tell you that I don't really believe in the anterolateral reconstruction approach. My preference is IT band-based operations, because I believe that the posterior part, the deep capsuloosseous layer of the IT band, is the most important restraint to internal rotation of the tibia. I do respect my colleagues here who disagree. But we've gone from this operation, worked in the lab and fine-tuned, and we can now do a modified Lemaire operation with a scar of as small as 4 and up to 6 centimeters length. So it's much more cosmetic and things have improved. So the indications have already been described, and I won't repeat that. But the problem we've got is to decide when to do this. Maybe there'll be radiological clues from Max's talk, we covered that. But there isn't a clinical test that tells us we have to do an anterolateral. So we just have to be practical and choose this sort of people. But I'd summarize and say I'd choose to do this operation anybody I'm worried about. And my experience in professional football has been good with this operation. Yesterday, I presented our clinical outcomes. And in summary, there's a single surgeon, that's me, consecutive series of isolated ACL reconstructions. We did include meniscal and chondral pathology, and we had a minimum 2-year follow-up. And footballers will not fill in PROMS forms. We're not going to get patient-reported outcome measures like KOOS, etc. But what we can get with almost 100% follow-up is big things like return to play, time level, etc., but also re-rupture rates. And so these are the things that are important to athletes, and we were able to measure them. So the operative technique in this series varied according to the time, and I previously and traditionally used an anteromedial bundle position in the femur, in the femoral footprint. And then eventually I was persuaded by Charlie Brown and Freddie Fu, amongst others, to change the central so-called anatomic position. Of course, an AM bundle position is not non-anatomic, it's in the footprint, so it too is anatomic, but they branded that name to mean the central footprint. And I used either a 4-strand hamstring graft or a patellar tendon graft. And in cases that I thought were high risk, I added a tenodesis. I always used a central footprint position on the tibial side for the tibial tunnel. So we had 232 consecutive cases, only 3 missed data. These players, these patients cannot hide. I can get the key data from their clubs, from their physicians, or even off the internet. 25% had bilateral ACL injuries, 17 of whom are in this study. So there is something about some people's knees that make them want to re-rupture. They're high risk. Thankfully, 96% got back to professional football and 90% were at the same or higher level. And we found that there was no effect of graft choice, the tunnel position, or whether or not they had a tenodesis on return to play time or rates. But you want to know about re-rupture, and that's what we're talking about today. Overall, my re-rupture rate in professional football is 8.2%. And I was a bit depressed about this initially. I thought it's a bit too high because the best reported re-rupture rates in footballers at 2 years from surgery are about 6%. So I thought, well, I thought it was better than this. Let's look at the detail. And this graph really summarizes it nicely. So I'll just talk through, I can't find a pointer. On the left-hand side, you'll see the high re-rupture rate. The worst results were for 4-strand hamstring in the central so-called anatomic position and not using a tenodesis, 18.5%. That was 5 of 27 cases. Thankfully, I gave a talk at Issachos, looked at my data and realized that moving from AM bundle to central bundle was a disaster. So thankfully I stopped doing it. And this is the value of doing clinical follow-up. If you placed a patellar tendon graft in the so-called central anatomic position, the re-rupture rate was around 11%. That too is too high. The central 2 bars, the black is the hamstring, the gray is the patellar tendon, showed a much less re-rupture rate by moving the tunnel to the AM bundle position. So for hamstrings, it was 10%, and for patellar tendon, it was 7%. So that's getting close to what I wanted to get. But if I then looked at the group on the far right of patellar tendon in the AM bundle and added a tenodesis, we have a 2% re-rupture rate. That's 1 case in 49 professional footballers. So now we're talking a big advantage of adding a tenodesis. Unfortunately, the really high black bar is of 4 cases only, and so we can't really make a judgment. There was 1 re-rupture, but that's obviously not statistically valuable. Well, I don't just treat footballers. What about my other athletes? I've got a series of 458 cases, which hopefully we publish shortly. And in that group, 60% were hamstring, 40% patellar tendon. There was 1 quad tendon. And I added a tenodesis in 25% of cases. The reality is nowadays I'm doing it in almost all athletes because of those results in footballers. And the re-rupture rate was 7.7% overall. If you looked at the hamstring cases, if you just looked at the ACL reconstruction intra-articular on its own, there was a 9.2% re-rupture rate. But if you add a tenodesis, it falls to a third of that at 3.4%. And so that's a really significant improvement on re-rupture rate. And there was no difference if you added a tenodesis and the morbidity to the patient or complication rate. So in conclusion, I would say that never-ending study of your patients will make you better because you will find out what works and what doesn't work. You have to be careful when you listen to my data because I have a very unusual life. 70% of my patients are athletes. So this may not apply to your practice because nowadays I'm almost always doing a tenodesis with my patient, certainly at least 90%. And the graft re-rupture from this study shows a great association with surgical technique. So choose carefully. And if you choose a patellar tendon in the AM bundle position and use a tenodesis in a professional footballer, you have a 2% re-rupture rate. Thank you very much indeed for your attention. This is the paper concerns and the authors, and these are my disclosures. Thank you.
Thank you, Andy, for this great presentation. Now it's my presentation. I'll talk about the clinical results of the anterolateral procedures. First of all, I want to thank my friends here from Brazil, and also Slard and Moscow for this great invitation. So I'll talk in English because my Spanish is not good as Aloysio's one, so I think it's better. So are our postoperative ACL reconstructions really satisfactory? If we look at the failure rate, and these studies are all recent ones, we will see that it has a range from 6 to 20% depending on the population you are studying. And if we look at the revision reconstruction results, we will see that the failure rate is quite high as well. If we check return to sports, we will see that the return to sports rate is not that good. So I think as a conclusion, we can say that our results are not as good as we think they are. And this is a phrase from 1968. Like, one of the most fascinating facets of the problem of the knee ligament injury is rotatory instability. You know, it's not the anteroposterior stability. Rotatory stability is the key when we are dealing with the knee. So you already saw a lot of anatomical and histological studies that Max showed you before. And there are like several interesting studies showing the anterolateral anatomy. And I think this is an important study that showed that in patients that have a preoperative anterolateral injury, the postoperative results after 2 years are quite inferior than the patients that have no anterolateral injury. So this is one important thing for us to look at. If you look at the systematic reviews around 2014, 2015, this is before the clinical publications regarding anterolateral ligament reconstruction, we will see that they supported extra-articular reconstructions. This is interesting. So according to these studies, the extra-articular reconstruction appeared to be really good for our patients, but why not to do it more often? In the past, there was this myth, I think, of increased pressure in the lateral compartment that truly happened when we use it to do isolated extra-articular reconstruction, but it did not happen when we do a combined intra-articular and extra-articular reconstruction. We have long-term follow-up studies, as Professor Zanfanini showed you this other study from Professor Ferretti, and this interesting systematic review from Australia showing that the clinical studies do not show increase in osteoarthritis when we add an extra-articular procedure. We know from biomechanics that in cases of combined injury of the ACL and the anterolateral structures, the isolated ACL reconstruction does not restore the knee biomechanics. When we look at the clinical results of extra-articular reconstruction combined with the ACL, this is a study from the French Society showing that the failure rate decreased from 15 to 7%. This is a great study from All Get Good showing that when we add a extra-articular procedure, the failure rate dropped from 11 to 4%. And we have a lot of interesting studies, as Andy showed us, regarding the benefits of the extra-articular tenodesis, no matter which technique we are using. Regarding specifically the anterolateral ligament reconstruction, this study showed a graft rupture of 1.1%, lower than literature average of 5.8%. And there are several studies showing benefits of the anterolateral ligament reconstruction, as this one we published it with the Sanchi group. In patients with chronic ACL tears, this is a study I did in University of São Paulo showing benefits of the S-articular reconstructions in patients that present with an injury of more than 12 months. And there are several other studies from all over the world, like this one from Korea, in revision ACL reconstructions, this one in professional athletes showing a graft rupture of 5.7%. This one, this prospective randomized trial also in athletes showing that the combined ALL reconstruction improved the results. Another important situation is hyperlaxity patients, as this study we did in São Paulo, showing that when we added the anterolateral procedure, we had lower rupture rate and better knee instability, sorry. And you know, all these combined results, now we have important systematic reviews with meta-analysis showing that when we do a combined anterolateral ligament reconstruction, we can have a lower rupture rate and better physical examinations, as this one we published in the end of the last year, I think. And it's important to mention that all these studies show that no major complications are related to this surgery. Normally, the complications are related to not a really good technique. So you have to be careful when you are doing these reconstructions, and it's possible to say that the complication rate is really low. So how to perform it? I normally do a single bundle reconstruction. It's like a horseshoe like this. And there is no restriction for range of motion. Actually, we normally do the same postoperative protocol as regular ACL reconstruction. So currently, I do this procedure, this combined procedure, in any patient with increased risk for failure. Normally, I do in around half of my primary cases and almost all my revision cases. So this is one example, a skateboarder, 21 years old, 3 previous lesions in the right knee and had a ACL tear in the left knee. So we normally do the combined reconstruction plus meniscus repair, and you know, you have to address all knee pathologies at one time. So I will show you how I do it. It's a very short video showing a football player. So we just draw the landmarks. I drill a tunnel for posterior and proximal to the lateral epicondyle. I use a triple semitendinosus and a single gracilis. We drill the tunnel from outside in, posterior and proximal to the lateral epicondyle. The tibial tunnel is done in a regular way as you are used to. So I just pass the graft and I fix the ACL with interference screws. And after fixation, I just drill another tunnel between Gerdy's tubercle and the fibular head, and I check the behavior of the ligament that must be tighter in extension and a little slacking flexion. This tunnel is freehand, it's quite easy. You just pass the graft under the ITB, and you just put the graft inside the anterolateral tibial tunnel and fix it with an interference screw in full extension. So this is the final result. Another option, as Andy showed you, is the Lemaire procedure. It's another good technique I normally use when I use the BTB or the quad tendon. So you just go under the LCL and you fix it posterior and proximal to the lateral epicondyle. I use it to use a screw, but I saw Andy using a suture anchor, and I started to do that, I think 3 or 4 years ago. And I think it's a very good option. I did a comparative study regarding anatomical ALL reconstruction in ITB tenodesis for revision cases. And the results are pretty much the same. So there is no great superiority of one technique over another. And I think the choice must be the surgeon's choice, which technique we have more experience by doing it. So this is one paper I published last year with 130 patients submitted to ACL plus ALL reconstruction with very good results and only 3 failures with this technique I showed you. So to end this lecture, I think our results are not always very good, so we have to think more about other possibilities, and the ALL or the tenodesis, the S-articular reconstruction is a good option for us to add, especially in high-risk patients. Thank you. Gracias a todos. Let me check the next speaker. Okay. Now, my big friend, Dr. Vitor Padua will talk about the ALL and the Lemaire biomechanics.
Well, good afternoon. Thank you, Camilo. Thank you again, Moscow, for the organization, for the invitation. I promise that next year will be Spanish and better Spanish speaking. So we're going to talk about the biomechanics of the S-articular reconstruction. So as Camilo said, today, the most 2 common S-articular reconstruction is the lateral tenodesis and the anterolateral ligament. So when you see the papers, like the old papers and more recent papers, they show that the S-articular reconstruction associated with the ACL reduce the strength to the ACL graft over 42%. And this reduce of the strength of the graft is most happening at 30 degrees and 15 degrees, or is when the pivot shift is going. So first, we're going to see the biomechanics of the knee. There is a physiological internal rotation in 90 degrees of flexion, and there is no internal rotation in extension. So that's a normal knee. And when you see an anterolateral ligament is the same. It's lacking flexion, which allows the internal rotation, and the anterolateral ligament is tight in extension as the knee works physiologically. So first, we're going to talk about the anterolateral ligament reconstruction. We have to remind that it's an anatomic technique, what means that we have to respect the anatomy. The anterolateral ligament, as Max has shown, is proximal, is posterior to the lateral epicondyle, and in the tibia is the middle way between the GRD and the fibular head. That's important because if you place the femur position of the anterolateral ligament in the epicondylar or anterior to the epicondylar, it's going to limit the internal rotation in 90 degrees of flexion. It's going to limit the physiological internal rotation, what's not good for the knee. But this paper showed that if we put it in the correct position, proximal and posterior to the epicondyle, is going to allow the internal rotation. And the ligament is not isometric. It's going to be tight in extension and is lacking flexion as anatomy. And we will allow the internal rotation. But we have to remember, you have to fix the anterolateral ligament in full extension. This paper confirm that when you do the anatomical position of the anterolateral ligament, it's going to control the pivot shift and it's not going to over constrain the knee. But the other side, the other hand, the lateral S-articular tenodesis, the Lemaire, is a functional technique. What means that is isometric technique and it's work as a pulley effect because it's go under the lateral collateral ligament, and the fixation, there is different description, but you can fix it from 0 to 90 degrees, and the more important, in neutral rotation. So there is some papers comparing both of the technique, and this paper show that if you do correctly, both of the techniques can restore the normal biomechanics of the knee. But remember again, in the anterolateral ligament, you have to fix it in full extension, and the lateral tenodesis in neutral rotation. This other paper confirmed the same things, that if you put 20 newtons in this both reconstruction, both of them are not going to over-constrain the knee. These two papers compare different kinds of lateral S-articular lateral reconstruction, and among all the different way to do it, the two techniques that we restore the normal biomechanics is the anterolateral ligament and then lateral tenodesis modified, Lemaire modified. So our preference is the anterolateral reconstruction, but we do some cases extraarticular tenodesis also, and we can do like Camilo showed in one bundle or two bundles. Our preference is the two bundles because it's going to simulate a poly effect when you do the rotation and extension and flexion. Another discussion is that the lateral reconstructions could lead to arthritis. But when you look at the literature, if you do like in neutral rotation, it's not going to happen. And the arthritis after the ACL is related to the meniscectomy and not to the lateral tenodesis. So in conclusion, we see that the extraarticular reconstruction works as a backup, as a protection to the ACL graft. And the most important thing to do is not to discuss which one is better. We think that as a knee surgeon, we have to know how to do both of them and when to use both of them. It's not to say which one is better than the other, but have to know how does they work. And when you see like a resume, is like the lateral tenodesis is isometric and the anterolateral ligament no. The fixation one is in extension and the other you can do in different degrees. The tension is the same for both of them. One is anatomical and another is functional. Both of them are not going to over-constrain the knee if you do it corrected, and both of the techniques are effective. So for finish, I just want to show this video from our group.
Frequency in ACL injured knees. The surgical landmarks are illustrated here. An anterolateral ligament reconstruction is demonstrated here. The graft is an isometric, being tight in extension, where it is able to control the pivot shift and slack in flexion, allowing physiological internal rotation and avoiding over-constraint. In contrast, the modified lemare is isometric. This means the graft is equally tight throughout the range of motion and therefore has a tendency to restrict physiological internal rotation in flexion.
Well, thank you for your attention.
Now I would like to call the last speaker, Dr. Sergio Canuto. He's one of my big friends as well. He's a former president of the Brazilian Society of Knee Surgery, and he has an important role now in Slard for us Brazilians. So, please.
Buenas tardes. Yo vou tentar hablar espanhol de nuevo. Portuñol.
Good afternoon. I'm going to try to speak Portuñol, Portuguese and Spanish. I'm going to talk about the complications of the anterolateral ligament and the LET. So they're not frequently done, but I've been doing them for 8 years now. And there are post-operatory and intraoperative complications. This article by Adam Getgood shows that when you have an ACL that is isolated with an ACL-associated lemare, there are very good results. Nevertheless, there is more pain in the initial post-operative period, so the first 3 months, and a bit of a delay in the recovery of strength in the quadriceps, as well as a reduction of the scores. The reduction of the strength of the quadriceps may be linked to regression of the fascia lata, the quadriceps, which leads to atrophy and pain. Lateral tenodesis. In Alan Getgood's article show a 15.3% rate of complications with LET, and for this reason, the authors of this group prefer to use the anterolateral method and lemare modified for revision. This article by Thornett had 548 patients with less than 0.5% of complications, and there are basically 3 cases to remove the femoral screw. No patients required a second surgery to cut the tendon, a tense tendon. There were no complications unless it was lateral isolated. They've discussed the increase of the progression of arthrosis. This was a piece of work from 91, with no follow-up. They've talked about this possibility, but two prolonged studies in France and Belgium with Professor Saffanini saw that there was no progression for arthrosis. This occurred in patients with meniscectomies, chondral lesions, and this is not linked to the reinforcement. The technique that I use is modification of the Bertrand percutaneous one, double band, and there's a connection phase. The most difficult technique is putting the needle through in the beginning. It's very quick surgery when you have experience, and I do this today in 5 or 6 minutes. Sometimes the passage can be complicated. It's open when you, it's more difficult to put it through when you open it. It's easier with stitches. We have distal or screws that can cause a lot of pain. Sometimes you need another operation. You can also tense it lightly. If you pull it too hard, it can break, as in this case. But there's no problem. You can fix it with a single tunnel, Camillo's technique, as shown here. In some cases, I insert quintuple intralaterally only. In this case, the graft is very short, and the same thing happens. So you fix it on the tibia, and you have a single band. Lemma is, with the lemma you need 8 to 9 centimeters of tendon. I like to put Vicryl in it to make it stronger under the collateral pull, and I fix it with an interference screw. Another option is an anchor to fix it, especially if you have problems with attachment or if you have a short graft. Sometimes there are some complications. Lemma is what I prefer to do in revisions and in women. As a conclusion, in my practice, 40% of the reconstructions are extra-articular, close to 300 to date, and I think we should all know how to do both techniques, so Lemma and the anterolateral technique. Using the patella, hamstring and quadriceps, my preference for LAL is 80%, and this is because it's minimally invasive. There are less complications. The mobility is practically the same, and many studies show its efficacy. And Lemma is used primarily for revisions in women with very thin grafts and with grotesque rotational instability. I like Lemma for this as well. Thank you very much. As you can see, our Spanish is getting better as the Congress goes by.
We have a few minutes for questions. If you have any questions, please. Moscow. Everyone, if you want to come here, I think it's easier. Se puderem vir acá, creo que es más fácil para. Moscow, por favor.
Gracias.
Moscow, please. Okay, thank you.
¿Tenemos traducción o toca en inglés?
Sí.
We
Do we have
trans-
translation or should we speak English?
Okay.
Yes, we do have translation. Okay. I'm ask the question in Spanish then.
Con alguna frecuencia, en caso agudo, hay una lesión de la raíz.
Sometimes there is a lesion in the posterior root, and as you had said in the beginning, this has a lot of influence on rotational stability. This is an acute patient with a large pivot, and you have in mind an extra-articular reconstruction, but you find the root, which was previously undiagnosed, but it's there, and you work on the root. Then you continue with the anterolateral plan that you had before. Do you continue with this anterolateral plan, or do you simply perform the reconstruction and the root only?
Por favor. No.
Please go ahead.
I can start.
Do you understand me, Sergio?
Yeah, you can go, Canuto.
Alô. Ok. É por isso que eu hago mais
This is why I prefer the anterolateral method, because I can do it in 5 minutes and it's percutaneous. And my experience with the anterolateral method, it also protects the meniscus and the ramp and others. And the post-operative process is the same, but especially with low demand patients, I use this method. And then when I finish suturing the root, if it's more stable and there's low demand, then maybe I will do the ACL. But I don't like to use Lemaire too much. But definitely for the quadrilateral one.
So it's a very good question, because obviously the root lesion added to the pivot shift. However, if that knee can pivot shift, there must be a loose capsule as well, and the anterolateral structures must be loose as well. And so actually you can fix the root, and that will help stop the pivot, but then those tissues are still lax. So my view is, why not just add a tenodesis as well? So I would do everything. But as I say, I do have a very unusual practice, and what I say may not be relevant to most people. So I have to be careful, but I cannot live with failure. It's a disaster for me.
Yeah, I agree. I think we need to repair the root, and if I plan preoperatively to do a extra-articular procedure, I normally repair the root and I do the procedure. I think we can do both. Sometimes people ask me regarding tunnel confluence, because you have 3 tunnels, but you know, the tunnel for the root is really small, and you can change direction, so it's quite easy and it's no big deal to do everything together.
And usually it's a lateral route, so the alternative is actually to take the suture tape down the ACL tunnel, because actually it's really close. So if I'm doing a posterior root repair of lateral meniscus, I do 2 luggage tag sutures, they go down the ACL tunnel, I make a trough. There's a few millimeters between the ACL tunnel and the best position, and the line of pull actually pulls it along the line, so it's really quick.
Okay. Yo he visto que todos están de acuerdo.
I have seen that you all agree that the lateral compartment isn't augmented. So when you perform a tenodesis or the reconstruction, in your opinion, does the compartment not augment in pressure? So in the practice in the lab, Dr. Lepre has performed methods where he says the contrary, any anterolateral procedure may increase this. When you have a patient with a weak meniscus and you have to perform ligament surgery, and then you have the primary revision, and then they also have a contralateral lesion, are you concerned about tenodesis or reconstruction?
¿Cómo sería ese gesto
And
quirúrgico?
what would you do in surgery to avoid increasing pressure in tenodesis?
So again, it's a very common question. I can't remember which speaker said that this idea that a well-done tenodesis or ALL reconstruction causes increased pressure is just a myth. It's not true. But we did show in the lab with Andreas that with a tenodesis at least, if you force the knee into maximum external rotation, really pull too hard and the tibia comes round, the contact pressure does increase. However, if you just pull at 20 newtons, so it's a bit like an MPFL, you don't pull too hard, and you keep the foot in the natural 10 degrees of external rotation, which we would call neutral, then you don't increase pressures. And the one thing you mustn't forget is what really gives you osteoarthritis is instability. And so if you get rid of a pivot shift, that reduces your risk of lateral osteoarthritis hugely. So one, I'm not frightened of causing overcompression and osteoarthritis. And actually, I want that compartment not to be unstable, because with ACL insufficiency, it's the lateral compartment mainly that has kinematic abnormality, as long as the medial meniscus is intact. When the medial meniscus goes, the wheels fall off, and then you get posteromedial osteoarthritis as well. So I think people are really overly worried about it. And but if you do the operation badly, that's different. Again, I can't remember, somebody mentioned that in their talk.
Yeah, I think it's important to avoid sternal rotation when you fix every S-articular procedure. You have to never fix it in sternal rotation. You have to fix it in neutral rotation. And you know, if you have a meniscus insufficiency or a big cartilage lesions, I think the patient can have osteoarthritis because of that. If you don't do an S-articular procedure and you do only the ACL, I think the result will be the same in like 5 or 10 years. I think the lateral procedure does not play a big role in that.
Me gustaría agregar que en la revisión sistemática que hicimos con los trabajos clínicos había un trabajo con 19 años de seguimiento. Y
In systematic review, there was somebody with 19 years and... Sorry, I didn't catch that.
Any more questions?
Sí. Si falla, es un escenario clínico.
Okay, so this is a clinical scenario. Let's say there's a young patient, 25 years old, involved in football. The ACL plus anterolateral, and there's a failure there. So how would you approach the anterolateral part?
¿Qué prefieren?
My preference is always
What do you
the
prefer?
That's why I said, as a knee surgeon, I think you have to know how to do both of them. It's like somebody said, you have to know how to do the patellar tendon, the hamstring, the quadriceps. So if it has a fail, if you did the anterolateral reconstruction, you can do the lemur without a problem, and vice versa. If you did the lemur before, you can do an anterolateral ligament. So it's the option that you have to know how to do them. You have to know how to fix them and how to work. And that's how if I did, you said in your case, I did anterolateral and hamstrings, I go to a patellar tendon and lateral tenodesis.
Any different options, Andy?
Whilst I respect everybody's view, I only just do a tenodesis. I don't believe in ALL, but it's a religious thing, and it's really, I wouldn't want you to worry too much, because both are good and they both work. And I've seen the surgeons who do ALL, brilliant surgeons, do a great job, and their results stand for themselves. But philosophically or religiously, I prefer to do a tenodesis. Let's not start the argument now.
How do you do that when you have failure?
Oh, failure, well, you can revise it. Yeah, sorry, I didn't understand. Oh, no, you can reharvest. I apologize, I didn't understand the question. Yeah, thank you. No, so with a tenodesis, you can reharvest a strip of IT band. I've done it many times.
And then you close it after?
Yeah.
And it's not a lot of tension?
No, so I close as far distal as the LCL. So I leave it distal to that, leave open, but I wouldn't do that anyway. But no, apologies, I misunderstood.
Just for the record, we are doing a interesting study with postoperative MRI. So in cases that we did a ACL plus ALL and that the ACL failed, and we can check the MRI, and the ALL graft is normally intact, and these patients normally they don't have major rotatory instability. So we are checking that, but fortunately we have like only a few cases of ACL plus ALL failures. So I think this study will take a few years more until we get a conclusion. But if I did an ALL reconstruction, I'm doing a revision, and patients has no other important pathology, and the graft is okay with no major rotatory instability, I know I just revised the ACL. Yeah. But this is ongoing. I'm not 100% sure this is the best option. Yeah.
So, Camille, do you not worry that if it's if the ACL's failed, the knee must be capable of a pivot shift, and therefore that tenodesis or ALL can't be working?
Well, I do think about that, but I think if it's not working at all, patient would have at least two pivot. Yeah.
Okay.
Yeah, two.
Yeah.
I have one question. There's a lot of important surgeons and a lot of ongoing studies regarding quad tendon in athletes. I personally use a lot of hamstrings and a lot of PTB, but I rarely use quad tendons. I use sometimes, but you know, if we check the rate, it's not big. What do you think, Andy? Are you using a lot of quad tendons? What's your opinion regarding that?
Well, the world seems to be very, or at least English-speaking world seems to be very excited about quad tendon. Not so much in the UK, but in the States, it really is the hot graft. In Australasia, Julian Feller, a close friend of mine now, has gone almost exclusively quad tendon without a bone block. But it shouldn't happen in medicine if we're really scientific, that we suddenly change.
Yeah,
it's like buying jeans, you know, it's the 7-year cycle, and surgeons are human beings and they get bored. So I'm using things that still work, and I'm terrified of failure. If you come to my talk this afternoon about my life in sports, you know, I was in the newspapers 4 weeks ago. It's not nice. So I'm going to choose things that work, but I'm tantalized by it. I'm not sure I like the fibrous nature of it. The lovely thing with the hamstring or tendon, there's straight line fibers. There's that Danish registry that did show increased re-rupture rate, but then two of my friends got together and decided that probably that was just one or two bad surgeons. Maybe it's true. I think it may be the perfect graft for dancers, because they have to have hamstrings to pull their heel right back, and they have to kneel on the ground. And I've done maybe 20. I've not had a failure, but I'm waiting. I think as you get older, you get more frightened.
Do you use, when you use it, you like the bone block?
Absolutely.
Yeah, surely. Yeah.
I love bone blocks.
Camilo, can I make a question? It's not related to the
Yeah,
anterolateral.
we have some minutes.
I
Yeah.
totally agree with you that you have to put the femur position, the anteromedial bundle. I totally agree with you.
Yeah.
And how do you do your tunnel? How do you perform your tunnel? Because I already have a discussion with Charlie Brown about that.
Yeah.
He tried to convince me that to put in the middle, but I didn't change it. I keep in the anteromedial.
Yeah.
And how do you do your tunnel?
So yeah, history is fantastic, and you must remember history, and we keep forgetting. That's the problem. And Charlie showed me, and Freddie showed me these beautiful pictures of ACLs, pictures taken from the AM portal. These graphs look amazing, and I thought, okay, I'll change. And my re-rupture rate 2.5 times. It was a disaster. So I drill via the AM portal. Now this will shock you, but I think maybe we'll go back to transtibial drilling, because it's pretty easy to hit the AM bundle position, as long as you have to make the mark from the anteromedial portal. So put in a stick, make a mark, and then drill up through your tibial tunnel. That's what I did for 15 years. But everyone said go to AM bundle. I do that, and frequently I now drill across the medial femoral condyle and cause chondral damage. So the only disadvantage of transtib, so if you have to make your mark via the portal, and then you drill up the tibia and hit your place. The only problem is if you've already drilled, when the drill goes up, it goes to the posterior part of the tibial tunnel, and you can make the tibial tunnel bigger. But it's so I still do AM portal drilling, because that's what everyone does. But I do wonder if we might go back to transtibial.
I don't know.
Which-
I think out to in is an easier way to do it.
Oh, yeah. And in truth, I don't, but I absolutely agree. I think it's out to in is very underrated. Very underrated. It guarantees you're in the right place. No, it does. And the trouble with trans-tibial, you can go too high in a notch. Yeah, absolutely. So I think out to in has been forgotten by a lot of people. No, it's very good.
Okay, I think we're out of time. This session was really great. I learned a lot. Thank you for all the speakers, and thank you, Slard, again for the invitation to be here. Thanks. Muchas gracias.
Thank you very much.
I love this discussion.
No, it's really.
No.
No.
4 years ago.
The other thing is, they say like, it's like that. Anatomic sounds better. It's from God.
Is anatomic also.
Victor.
I like this discussion because in Brazil they
I went out for lunch with him, actually.
No.
Go in the middle. Go in the middle. Go.
No, please.
I can breathe.
Thank you.
Thank you, Max.
No, not at all. No, but it's
Take one more time.
oh no. But in medicine, it's just